Good evening, friends. Last week, Alka ma'am took a very nice lecture on common fevers in thrombocytopenia. Today, any fever, viral fever is giving thrombocytopenia. So I thought since the fevers are increasing, not only in my practice, but we have a group of municipal corporation of Greater Mumbai of our ward where we have to inform about our cases, malaria, dengue, typhoid, the phone number and the address so that the authorities visit them and take precautions of mosquito prevention. I see many cases of malaria and dengue are happening, maybe less of leptospirosis. So I thought, let me cover treatment of these. The treatment of malaria, Vivex, chloroquine phosphate in full therapeutic dose of 25 milligram per kilogram divided over 3 days still works because most of the practitioners have shifted to artemether. Chloroquine still works. I use chloroquine as the first line of treatment. 500 milligram stat, and then after 8 hours, that is a very complicated dose for the patient. Suppose you give first dose in the evening at 7, the next dose is due at 3 a.m. and then every 12 hours, that becomes very difficult. Nowadays, the treatment recommended is 2 tablets of DS, either Lariego DS or Maliego 500, 2 tablets on day 1, 2 tablets on day 2, 1 tablet on day 3. You get a strip of 5 tablets. So if I'm giving now at 6 o'clock, I will first give a Ondacentron. Then after half an hour, I will give 2 of chloroquine DS with a glass of chilled milk. I'll repeat the same thing tomorrow 6 p.m. and day after tomorrow, I will repeat 1 tablet. Vivex malaria relapses are common and they are due to hypnozoites, which is a stage in the development of Plasmodium in the liver. The relapse rate in Vivex malaria in India is around 30%. And believe me, this relapse rate is because one of our brothers or sisters has forgotten to give Primaquine. So what is a hypnozoite? Hypnozoites are the dormant forms in the life cycle of certain parasitic protozoa, malaria being one, and best known for their probable association with latency and relapse in human malaria infections caused by Vivex and Oval. Although Oval is not seen in India much, but since we have audience from all over India, even smaller tier cities, if you get a positive smear of Oval, the treatment is just like Vivex malaria. Primaquine is given at a dose of 0.25 milligram per kilogram daily for 14 days. For an adult, it is 15 milligram for 14 days, 7.5 milligram tablet BD or 15 OD for 14 days. And we have to do G6PD before we give Primaquine. And if the patient is deficient in G6PD or patient is below 1 year, or a pregnant woman, primaquine should not be given. Commonest side effect of primaquine is hemolysis. Primaquine can lead to hemolysis in G6PD deficiency. If suppose sometime you decide to give somebody primaquine without G6PD test because the patient cannot afford, you should advise them to stop primaquine immediately if the urine gets dark colored, they get yellow conjunctiva, that means indirect bilirubin goes up because of RBC lysis, cyanosis or bluish discoloration of lips, abdominal pain, maybe bleeding is occurring there also, nausea, vomiting, and they should report immediately. But caution is, do not give, because if any of this happens and the bleeding is intense, it will be your blame, not the patient's economic condition. Coming to falciparum malaria, artemisinin combination therapy or ACT should be given to resistant areas where chloroquine can be used in sensitive areas. Ideally, the first line of treatment of falciparum also is chloroquine, unless your area is chloroquine resistant. ACT should be given only to confirmed Plasmodium falciparum found positive either by microscopy or rapid diagnostic test. Should not give empirically. It consists of an artemisinin derivative combined with another drug, a long-acting antimalarial, which could be amodiaquine, lumefantrine, mefloquine, or sulfadoxine pyrimethamine. ACT is being used in national malaria programs. There are questions which we'll take later. The ACT used in the National Program of India Malarial Treatment, artesunate with sulfadoxine pyrimethamine, brand name Larinate. Other combinations available: fixed dose, artemether, lumefantrine, Lumerex 80, artesunate mefloquine, Falcigo Plus. They are available in the country. Other ACTs which will be registered and authorized for marketing in India may be used as alternative because regularly newer brands keep coming in. Artemisinin derivative must never be administered as a single drug. You have to have a combination. These rapidly acting drugs, if used alone, can lead to development of parasitic resistance. Which patients qualify for ACT? Patients with history of travel to listed high endemic areas. Patients like, few years ago, there was a big epidemic in Surat. So there we would never give chloroquine, we would give ACT. No clinical or parasitological response to full dose of chloroquine within 72 hours of starting therapy. Why we wait 72 hours? Provided patient's vitals remain same and platelets are not dangerously low. ACT in pregnancy, according to current WHO guidelines, ACTs can be given in second and third trimester of pregnancy. The recommended treatment in the first trimester of pregnancy is quinine. IV quinine is safe even in first trimester of pregnancy. Many times you get mixed infection, although rare, Vivex plus falciparum. Mixed infection with falciparum should be treated as falciparum. We prefer with ACT primary therapy rather than trying with chloroquine. Now, the national guidelines say that your rapid diagnostic test is negative and smear is going to take time. So the guidelines say that you collect blood and you start chloroquine. If RDT for only falciparum is used or even Vivex, negative cases showing signs and symptoms of malaria. Although signs and symptoms of textbook picture malaria are not seen nowadays, but fever coming following chills. First chills, then fever. Patient, if eating and drinking well, appearing virtually normal in between episodes, and the episodes coming roughly once a day or once in 2 days. These are classical symptom signs. It should be taken as clinical malaria and treated with chloroquine full dose. We don't want to start ACT combination as clinical malaria. And if smear is positive, then you decide what treatment you want to give. Then for uncomplicated malaria, let's look. Avoid starting treatment on empty stomach because they are severely acid-prone medicines. The first dose should be given under observation. Dose should be repeated if vomiting occurs within 30 minutes. This is specific. Vomited after 45 minutes, no need to repeat. Vomited at 25 minutes, repeat the dose. The patient should report back if there is no improvement after 48 hours or if the situation deteriorates. I don't think we should wait even 48 hours. What I personally do is I give all my fever patients a temperature chart, which I think a year or two back I had shared on the group. I give a temperature chart which has the instructions of what diet they should take. And I ask them to take armpit reading every 2 hours and send me by WhatsApp once in 24 hours. So you know how the fever is behaving. The patient should also be examined for concomitant illnesses, especially immunocompromised. You know, we all get a horse's vision. If my dengue NS1 is positive, I stop thinking of other infections. Clinically suspected malaria, smear awaited, RDT negative, but clinical features give you a hint of malaria. Slide for microscopy taken or sample collected to be sent to the lab for smear. P-Vivex, chloroquine 3 days, primaquine 14 days. And if you're waiting for smear, you start chloroquine 3 days. And when smear is Vivex positive, you give primaquine. Falciparum, ACT 3 days, primaquine single dose. I'll show you what single dose. But I have lately received a notification from my municipal corporation group, the BMC doctor, that primaquine should be given 14 days to all patients Vivex or malaria. So you should check in your region. And if it's negative, you evaluate further what other infection it could be. The dosage for chloroquine, these are number of tablets 250 milligram. So 15 and above adult 4 tablets or 2 tablets of 500, 2 tablets of 500 and 1 tablet of 500 as I explained in the beginning of this talk. If you do not remember the dosage, no need to mug up. Get the patient to buy the medicine, and on the product insert, the dosages are given. Primakin for Plasmodium vivax, daily dose adults 15 milligram per day or 7.5 BD. And if it is a 2.5 milligram base, then 6 tablets. Primaquin for falciparum, single dose on first day. Now see, 7.5 milligram to 45 milligram base. This is not my brain. This is from Government of India guidelines. But must check current guidelines issued by local authorities, because as I said, I got one that it should be given for 14 days. So you please check in your local authority. ACT, artesunate plus sulfadoxine pyrimethamine. Dosage schedule for Plasmodium falciparum, where chloroquine is not working. In adults, first day, 4 tablets of artesunate and 3 of SP. Second day, only artesunate. Third day, only artesunate, 4 tablets. Severe malaria. One word of caution when treating malaria or dengue. Nowadays, what has happened is that people don't call patients to the clinic. They just ask for reports on WhatsApp. But you need to check vitals. I have a patient who was diagnosed NS1 dengue day before yesterday. I called him today because his platelets were down to 111, 1,11,000. And we found BP was 90/60. He had taken 2.5 liters of fluid yesterday. Pulse was normal. We instructed him to consume 3.5 liters today with 1 liter of ORS, half liter of buttermilk. At 4 o'clock, BP checked was 110/64, and he was not feeling weak at all. So understand, dengue or malaria, hydration is very important. So please, for first 3 to 4 days, call patients to the clinic. Severe manifestations can develop in falciparum over a span of 10 to 12 to 24 hours also, and if not picked up, may lead to death. What are the symptoms of severe malaria? Altered sensorium coma. Coma is ultimate. Altered sensorium in any fever is a red alert. Repeated convulsions, again, of course, you will never try to treat convulsions in the clinic. Renal failure, creatinine above 3. So patients who are diabetic, patients who are hypertensive, diabetic, specially uncontrolled, check creatinine if you're dealing with dengue or malaria or leptospirosis. Because leptospirosis also affects kidney as well as lungs. Jaundice, you see deep icterus and you see total serum bilirubin more than 3 milligram per DL. Severe anemia, 5 gram or less. This becomes critical if the first report had shown 9 or 10 grams. Pulmonary edema, ARDS, SpO2 dropping below 85 or 80. And on examination, you see bilateral crepes. Hypoglycemia, plasma glucose below 40, but even below 60 is worrying. Hypoglycemia is very common in falciparum, severe falciparum, because parasites consume sugar. Metabolic acidosis, you will know only by blood gases, which we don't do in the clinic. But if the patient is appearing breathless or complaining of shortness of breath, you take it as metabolic acidosis. Collapse, systolic BP below 80, diastolic below 70 or in below 70 in children. And any abnormal bleeding or DIC, we don't wait for DIC. Even if it is a bleeding from nose, which is not flowing, just trickle. Patient may say, I blew nose, I put my finger in, doesn't matter. I will not take it lightly. Then if your urine shows hemoglobinuria, patient has fever above 104. And good laboratories will give you a parasitemia index. Parasitemia is what percentage of RBCs from total RBCs of the body are infected with malarial parasites. About 2% is critical. Above 5% would be life-threatening. About 10% is kind of certain death. And even in municipal hospitals where there is no bed, a malaria with parasitemia, 5% will be admitted without any ado. Fetal and maternal complications are more common. So pregnancy and severe malaria or pregnancy in malaria should ideally be hospitalized. Specific antimalarial treatment for severe malaria. I have an urgent call. I'll just pause for a extremely sorry. One patient is hospitalized, so I had to take the call. So artesunate, if you are giving IV, then please remember these dosages: 2.4 milligram per kilogram IV or IM given at admission, means in the clinic at 0 hour, then 12 hours, then 24 hours. It should be diluted with soda bicarb provided in the pack. Quinine, 20 milligram quinine salt per kilogram IV in dextrose or dextrosaline over a period of 4 hours. Infusion rate should not exceed 5 milligram per kilogram per hour. Loading dose of 20 milligram per kilogram should not be given. It should be given slowly. There is no loading dose. There is never give bolus injection of quinine. If parenteral quinine therapy needs to be continued beyond 48 hours, reduce the dose to 7 milligram per kilogram 8 hourly. You may say that we never give, but you know, the kind of endemic was there in Surat or Gujarat few years back. Every general practitioner was giving quinine IV in the clinic, and there are no places to keep patients. So patients would hold the bottle and go back home in the rickshaw. That kind of thing was going on. Artemether also can be given IV if you have a nursing home setup where you admit patients. Once the patient can take oral therapy, further follow-up treatment should be as below. Patient receiving parenteral quinine should be treated with oral quinine, 10 milligram per kilogram 3 times a day. Approximately, you get capsules of 600 milligram TDS. If it is not severe, you may start with oral only. You may not give IV first. Along with doxycycline, 3 milligram per kilogram per day for 7 days. Doxycycline always is contraindicated below 8-year children, pregnant women, and there we can give clindamycin 10 milligram per kilogram body weight 12 hourly for 7 days. Patient receiving artemisinin derivative should get full course of oral ACT. However, ACT containing mefloquine should be avoided in cerebral malaria because it has neuropsychiatric complications. IV preparation should be preferred over IM preparations. In first trimester of pregnancy, parenteral quinine is the first drug of choice. It is safe. If quinine not available, artemisinin derivative may be given to save life of the mother. Fetus is not guaranteed, but at least mother can be saved. In second and third trimester, parenteral artemisinin derivatives are preferred over oral. Severe Vivex. I have myself seen cases in last 10 years. So I have added this. Initially, we used to think Vivex is a milder version of malaria, but I have seen patient with ARDS requiring ventilator for 4 days, a patient getting acute renal failure, taking 1 week to recover, and an altered sensorium with encephalopathy, which of course turned out to be severe electrolyte imbalance. There is reason to fear that this problem will become more common in coming years. Why? Because we have seen, I'm sure you all have noticed, immunity of our patients is getting lower and lower. People are resorting more to self-medication. They reach clinic late by the time the things are worse. And then half the time they bring reports in hand. Today, a patient came to me 4 days of fever. He brought CBC, CRP, routine urine. CRP was 62. Why wait for 4 days? Severe malaria caused by P. vivax should be treated like severe P. falciparum by artemisinin combination therapy. Coming to prophylaxis. Nowadays, with tourism increasing, we have to give prophylaxis to people. Chemoprophylaxis for travelers, migrant laborers, and military personnel exposed to malaria in highly endemic areas. There are certain construction projects where we give the laborers chloroquine DS 1 tablet every week. Because even the contractor is happy to do that, it prevents malaria in them. All recommended primary prophylaxis regimen involve taking a medicine before reaching that destination, during the stay, and afterwards. So if a patient is coming to Bombay in the month of monsoons from United States, I will tell them to start medicine prior to leaving and then continue throughout the stay in Bombay, whether 1 week, 1 month, 1 year, and then 4 weeks after going there. And pregnant women have to be encouraged for mosquito prevention, mosquito bite prevention. Less than 6 weeks, Doxycycline, 100 milligram daily in adults, and in children above 8 years, 1.5 milligram per kilogram body weight. The drug should be started 2 days before travel, continued throughout the stay in that endemic area, and then 4 weeks or 28 days after leaving that area and coming back home. Doxycycline contraindicated in pregnant women and those below 8 years. More than 6 weeks, if the travel is more than 6 weeks, mefloquine, 5 milligram per kilogram body weight up to 250 milligram a day every week, and should be administered 2 weeks before, during, and 4 weeks after leaving the area. So in US, many times they don't get chloroquine, so we tell them to take mefloquine. Make sure the patient is not on any treatment for psychotropic drugs. Mefloquine is contraindicated in patients with history of convulsions, neuropsychiatric problems, and cardiac conditions. If the travel is more than 6 weeks, chloroquine adults 300 milligram base or 500 milligram tablet once a week. And children 5 milligram per kilogram maximum is the adult dose once a week. Begin 1 to 2 weeks before travel, once a week during travel, and 4 weeks after leaving the area, coming back to our own place. Then good choice for long trips because it is to be taken only once a week. Some people, there are patients who are on treatment with HCQ or hydroxychloroquine for chronic rheumatological condition. They need not take any separate prevention for malaria if they're going to endemic zones. Can be used in all trimesters of pregnancy, chloroquine. Short term, primaquine adults 30 milligram base daily and children 0.5 milligram per kilogram up to adult dose daily. Begin 1 to 2 days prior to travel, daily during travel, and just 7 days after leaving. One of the most effective medicines for preventing P-Vivex. It's a good choice for travel to places which has more of P-Vivex and not more of falciparum. It's a good choice for short trips because it has to be started, taken only 7 days after coming and not 4 weeks like other medicines. Good for last minute travelers because the drug is started 1 to 2 days before only, not a week before. Of course, we know that it cannot be used in patients with G6PD, cannot be used in patients who have not been tested for G6PD, cannot be used by pregnant women, cannot be used by women who are breastfeeding unless the infant has also been tested for G6PD. Recurrent malaria. Recurrent malaria may be a misnomer. Is it recurrent or is it relapse? A friend of mine came from Delhi. She was a gynecologist. She stayed at Powai. In 1 year, she got 3 episodes of Vivex malaria. And we knew it was recurrent because every time she had taken primaquine. Then she went back to Delhi. She said, Bombay is not suiting me. Has the patient taken treatment completely? Many patients nowadays stop treatment saying garam dawa hai, gives me a lot of burning and all that thing. Incomplete treatment. Good. Mistake of doctors. Forgot to give primaquine. Currently, Primaquine is the only treatment available to prevent relapse of Plasmodium vivax. Coming to dengue. Dengue, as we know, has no specific treatment. Treatment in the early stage of dengue is oral rehydration therapy and paracetamol for fever or pain. Avoid NSAIDs, avoid aspirin, ibuprofen, diclofenac should be avoided that increase the risk of bleeding. If symptoms progress to dengue hemorrhagic fever or dengue shock syndrome, then medical care is critical. Patient should be hospitalized. Now, this is one scenario I have seen in practice in last 1 year, especially in dengue and malaria. See, dengue knocks down the patient's immunity, malaria knocks down the patient's immunity, and they get a secondary infection. Dengue, of course, when we treat the patient's dengue and the patient becomes afebrile and normal, you have to caution them, especially if in this case, IgG was negative. That means this was the primary infection of dengue. You tell them in next 1 month, even if you get a fever of 99, come to us or get a IgM, IgG done again, because the secondary infection of dengue has a higher risk of dengue hemorrhagic fever or dengue shock syndrome. Commonest secondary infection is typhoid in patient who are susceptible. Who's susceptible? Who consumes unhygienic food and water. Pneumonia in uncontrolled diabetes mellitus. And UTI, if the patient is in dehydration, they get UTI. But dehydration alone can be a catastrophe for dengue patients. Leptospirosis, we have to have a high index of suspicion, especially the history of wading in water. Leptospirosis treated with antibiotics like doxy or penicillin group. Doxy works best, but if you can't give doxy, amoxicillin, ampicillin, penicillin G or ceftriaxone. Antibiotics should be started as early as possible. Leptospirosis is a bacterial disease. IV antibiotics may be needed for people who have severe symptoms. Identify respiratory distress, acute renal failure, and advise hospitalization if you feel the patient's lung or kidney is affected. So a leptospirosis positive IgM gets 1 episode of hemoptysis, needs hospitalization, has oliguria or raised creatinine, needs hospitalization. Prophylaxis, doxycycline 200 milligram orally once in a week is given in flood situations where people are going to be wading in water for we don't know how long, or wartime in jungles. That is the leptospirosis prevention. In Bombay or in India, where people wade for 1 day or 1 hour or 2 hours or maybe a day or two, 100 milligram BD 5 days suffices as a prevention. That's all for today, friends. Primaquine prophylaxis again I'll show. Temperature chart will be given. G6PD, Dr. Manoj Haldar, is glucose 6 phosphatenase deficiency, dehydrogenase. If not Primaquine because of G6PD, what is the alternative? Then you give chloroquine 500 once a week for 3 to 6 months. So temperature chart will be given in Word format on Telegram group. You can delete my name, put your own name, print and give it to people. Mefenamic acid, still Dr. Kayur is a NSAID. I would avoid it. See, above 104 fever, no. The best is paracetamol and full body sponging or a shower with lukewarm water. How to differentiate between recurrent and relapse? If you are sure that patient has, if Vivex malaria patient has taken Primaquine 14 days, second attack is recurrent, not taken Primaquine 14 days, that is the relapse. Diagnostic test for leptospirosis, IgM lepto. Mefloquine can give long-term tinnitus. Yes, Rohit, very right. That's why in India, we don't use mefloquine much. Leptospirosis prophylaxis, Primaquine prophylaxis. Okay, I'll share 2 slides now. Slide 39. How often should paracetamol be given? See, paracetamol, I normally give need-based. Because no point in giving 650 milligram paracetamol to a 70-year-old person 3 times a day. I just say that if it crosses 101, you take it. I ensure hydration. I don't give paracetamol round the clock. Unless the patient has severe URTI, I'm giving a tablet with paracetamol, chlorpheniramine maleate, and phenylephrine. Let me see, I'll share the slides. Leptospirosis prophylaxis. Primaquine prophylaxis. See, what I'll do is the dosages and the prophylaxis slides only, not the entire presentation. Those who want to request Preeti will be given directly to you in PDF format. Malaria, IgM, malaria is generally tested for the antigen. Malaria antigen, Vivex or falciparum. CBC picture in malaria, generally you will see anemia because the RBCs contain the plasmodium and they rupture when the plasmodium are released. So very likely you get hemoglobin low. And if you do a liver function test, you may find indirect bilirubin high, mild SGPT, SGOT are normal. This is again because of RBC lysis. Dr. Ufri Zenani, kiwi, dragon fruit, nothing works. Dragon fruit, when it came to India, it was an expensive fruit and they just started a scam. I hate seeing poor people who can't afford a banana buying dragon fruit for this. Do we get to see classical malaria picture now? Yes, I have seen just last week one case. 3 a.m. shivering and fever of 103. Whole day fine. She came to me with her husband and I didn't know who was the patient. But such patients are rare because, you know, there are people who are taking Dolo and Combiflam like Cadbury gems nowadays. They will not give you a classical picture. People who are not abusing medicines will give you a classical picture. Mixed infection will be only test based. You can't suspect. Like I just had a patient, a young girl of 14 years with dengue. Platelets went down to 90,000. Third day, platelets are 210. And the fever is not coming below 102.5. Then she started loose motions. We did IgM typhi. It was positive. The fever touched 104, 104.5. She had to be admitted. And blood culture was positive for salmonella. So it is the high index of suspicion. Carica, papaya, and dengue, I don't use at all. Many times they may itself give complication. See, even WHO says dengue is a self-limiting condition. You manage hydration, you make sure thrombocytopenia doesn't worsen the patient's life. Dr. Sheetal Gupta is asking how to distinguish which type of fever patient is having nowadays. This patient come with CVC, CRP, urine routine. If urine routine is showing pus cells, RBCs, bacteria, and there are symptoms of urinary tract, then you treat as UTI. But if the patient has body ache, then UTI and dengue can come together. So I have a very simple thing. I ask the patient, whichever language, whichever socioeconomic status, education status, I ask them, I give you a scale. Body pain, 1 to 10. 10 is the worst pain you have got. Where are you? They say 8 or 9. These patients, 90% come out to be dengue. Below 5, I don't even do test, I just do CVC. Role of steroid in dengue, please avoid. Unless the platelets are very low and they're not coming up, avoid steroids. Avoid steroids in dengue, in typhoid, please avoid. What if the fever is not responding to PCM in dengue or malaria? Is it alarming sign? See, anytime the fever is not going no, or every time you talk to the patient no, you ask hydration, hydration, hydration. If the patient is hydrating and fever is not going, then think of second cause. Commonest second cause is enteric. Many times, even we have been fooled. Fever of 105. And then you do all possible fever profile, everything negative, 24 hours the fever breaks, viral fever. So always take a history of nutrition, milk, curd, fruits, and hydration. And in our clinic, all my assistant doctors, all my non-clinical staff will keep telling patients, pani piyo, pani piyo, pani piyo. So I think hydration is the savior. Mefenamic acid safe in dengue? No, it's an NSAID. Avoid. IV fluid recommended in dengue with dosage. IV fluid, ma'am, if you're giving, you have to give as per the patient's body weight and the level of dehydration. Chikungunya fever, again, you have to do IgM chikungunya. You cannot. Chikungunya will have more of joint pains than fever, not a body ache. Dengue will have a body ache. Chikungunya will have joint pains, spine as well as this. So IgM chikungunya will confirm it. Thank you very much. See you next week.